Thank you, Sarah, and thank you for inviting us to this so interesting and critical meeting. I'm Carlos Cordon-Cardo, and I'm the chair of the Department of Pathology at Mount Sinai. And the work that I'm going to present is really the efforts of many of the colleagues. As you probably know, we had a very difficult time during very hectic periods in New York in the pandemic of COVID-19. And at the end of the day, you need a diagnosis, you need monitoring, and you need to understand the disease. And this is part of what we in pathology produce. Part of the mandate of pathology is to produce, diagnostics and some managing tools for individuals to have or to be suspected to have a disease, in this case COVID-19, providing testing and assisting in a stratification, planning, and monitoring, as well as trying to understand the biology of the disease, the range of organ damage, and it's for the reason that we uncompromisingly perform one of the probably largest autopsy series of COVID-19 with more than 120 complete autopsies being performed as of today. And from the very well beginning, we knew that was not a matter of if, but a matter of when. And as laboratorians, we wanted to not only produce qualitative assays in any of the context of what we were going to do, but also qualitative and quantitative. We wanted to say yes or no, but also we wanted to have some kind of metrics, and we wanted to go deep in order to see if these metrics were going to help us in better understanding the disease and stratifying the patients. So in the context of a diagnosis, we had some platforms for PCR, for high throughput, to identify the presence of SARS-CoV-2, but we also decided from the beginning to produce a viral load, to understand if individuals were high, intermediate, or low in their viral load, and if this kind of data was going to help us in better understanding the disease, the stratification, and the symptomatology of the patients. We also have been involved in phylogenetic studies that we'll not discuss because it's being conducted with a large group of collaborators internationally. Once we had the diagnosis in place, we decided to do something similarly for serology and for follow-up of the patients. So we developed our own serology assay, which I'll present, for antibody detection. And we use that not only to identify if the individuals already seen the disease, but also the titers, if people were developing a real robust immune response. We did the same with platforms for a specific interleukin, since these patients develop, cytokine storms. And finally, we wanted to create a bank that is open to everybody, and that it's the compilation of a series of autopsies that have revealed that this disease, initially to be thought to be essentially a respiratory disease, it's something that we didn't expect and can present in very different formats. And we have been able to produce, again, this collection of body fluids and tissues that I'm here to say that it's also not only for us, but for the international community to be able to undertake specific studies. As of today, we have done around 180,000 SARS-CoV-2 viral studies. As you can see in this slide, in the beginning of the pandemic, most of the days our laboratories were in a great deal of stress, with 60 to 70% detection rate during April and March, April and part of May, and then it started to decrease. In the last few days, we have seen a little bit of a surge in New York. The date of detection as of today was 1.9 for our large community. But also from the very beginning, we see that the CT curves that every day are obtained, some of them are where you expected. The cycles of amplification start between 28 to 30, 35 being at the middle and the peak later. But we observe that some individuals had CT curves that started very early on and some that very delayed. So we started to classify and then to produce a second assay for real viral detection of viral copies in order to understand what was going on, to realize that viral load is significantly associated in multiparametric analysis as an independent factor for disease progression and aggressiveness of the disease. So it's very important from the beginning to understand that this may be one of the first tools that we may have to stratify patients. If somebody has a very high viral load, it's going to be definitely a big spreader, and he's going to be probably very sick. And this Kaplan-Meier. It's of a recent publication from our group of hospitalized individuals that came with a very high viral load, and as you can see, individuals with a very high viral load did, quite poorly. As we move from understanding the diagnosis and what we need to do into the monitoring, we need to also to make sure that you understand that it takes time to our immune system to produce these antibodies, that they are going to be the most important battle that we are going to have to win over the SARS-CoV-2. And we produce a test that I'm going to introduce to you, that is ELISA-based, that we have been using to identify donors for convalescent plasma therapy, to confirm if somebody has had the disease. We are planning also to use it to measure titers in the context of a specific clinical trials, as well as in vaccination studies. And it takes around 18 to 20, 21 days, 28 days in order to really see the immunoglobulin IgG coming as the one that you want to be monitoring, because it's the one that is going to have functionality in the context of binding to the spike protein and producing neutralization. So our assay, most of the assays are based on identifying the spike protein. It has an important connotation, since the spike protein is also the one that binds to the cells through the receptor binding site, to the ACE2 receptor. And it's also the one that is going to be seen by the immune system and is going to create that immune reaction with the antibodies that are going to produce, when studied, the neutralization and the functionality. So our assay, it's an assay that has two parts. The first part is against the RB binding domain, and the second is against the entire S protein that gives you a quantitation, initially done with a titration, and more recently we passed that into arbitrary units and nanograms of immunoglobulin per ml. And the positive predictive value and the negative predictive value of the test are very high, both for specificity and sensitivity. So we have done over 70,000 of these tests. We have been able to identify more than 25,000 donor-eligible individuals that have a very rich antibody blood in order to donate plasma to people that they are very sick. And what we have learned is that titers are important. Again, like in the diagnosis, yes or no, qualitation, it's fine, but it's not sufficient probably. In this, the important task that we have is to make sure that we have quantitation, because when we look at the titers and at the levels of antibodies, and we correlated that with microneutralization assay, the amount of functionality that these antibodies have, if they tell you that you are positive, but they don't tell you that you're at 1 to 80, the reality is you're going to probably produce a very small amount of real killing of the virus. You may not be as protected as you think. And when you look at the cutoff values for IC50 in neutralization, you need levels of around 320 to start feeling comfortable that you have enough antibodies that they are functional, that they are going to be able to battle. And this is going to be critical for frontliners to many other groups. If one thinks that it's antibody positive, but you don't know your titers and your titers are low, and you want to go and to help society, chances are that you may become sick again. So very critical in the diagnosis, not only to have a specificity and sensitivity, but to have a quantification, so we can stratify patients and we can better understand what's happening with a seroconversion and with the immunity that the community is getting. And this has been important because once we have identified individuals that they are with very high titers, and we call them in order to be donors of their plasma, we had an incredible response. We have been able to treat over 500 patients with convalescent plasma. And when the individuals that they are very sick, but not in a respirator, inside of the hospital and respirators, with this kind of convalescent plasma therapeutics, we have been able to produce survival rates that they are around 90%. While individuals that they are very sick and already in respirators, we are seeing that there is probably a different kind of disease as I'm going to present. So to be able to stage the disease and to be able to treat at the right time, we think that it's going to be very critical. So we have seen that this disease can present in different formats. We were very much disturbed from the fact that some patients came with a very severe and critical symptomatology that didn't really fit the models that we expected from the point of view of other SARS and what we were expecting of SARS-CoV-2. So it's because of this reason that we decided to go deeper and perform autopsies and try to understand the pathophysiology that SARS-CoV was producing in different organ types. And I'm going to illustrate that with two specific autopsies that we perform. The first is the typical respiratory autopsy. The second is going to be the one that surprises the most and has given us some interesting information about the organ damage and the kind of tropism that this virus has. This is the case of a 57-year-old female that was admitted with fatigue, with cough, with shortness of breath, not much of fever, really 37.3. It's not really fever in my book. And this is something that we may want to discuss at some point. The reality is that the concentration of oxygen was coming down, and essentially the markers of inflammation were all very distorted. The C-reactive protein, the normal values are between 0 and 1, and you can see here this patient had over 270. Similarly to ferritin, that the normal values are around 100, this is 760, and so on and so forth. And the reality is that more than lymphocytosis, most of these patients came with lymphopenia. Patients started to do very poorly, and all of a sudden, the concentration of oxygen is 60%. You cannot live with this concentration of oxygen. There is major damage in many organs and shutdown, and the patient expired. So what we learned in this first autopsy is that rather than a lung that was going to be very collapsed and with a lot of inflammation, it was relatively clean, but it surprises the amount of hyaline membranes, these kind of barriers that are produced between the air of the alveolar spaces, that it's not allowed to go through the blood vessels. So this is the cause of hypoxia, these membranes, these hyaline proteinaceous membranes that they are producing this barrier. And where are the cytokines coming from? What is all of the inflammation coming from? So to make a longer story short, we learned that more than activated lymphocytes, what this syndrome is presenting, it's very angry macrophages that they are producing phagocytosis all over the body and in specific sites more, producing this kind of macrophage activating syndrome that has been also described in some other diseases. For example, in the canonical conventional Kawasaki disease of children, the major source of inflammation and cytokines comes from this so-called macrophage-activated syndrome. And this is just an example of the typical bacterial pneumonia compared to the, viral pneumonia of the COVID-19. As you can see in these individuals, the spaces are completely replenished with inflammation, with bacteria, contrary to what we are seeing in this kind of SARS-CoV-2, in which the major reason for really not having enough oxygen is because of these membranes that they are produced in the context of this proteinaceous material that is accumulated. So what we have learned from this group of autopsies, that the lung, it's one of the major areas of attack. We have seen the typical conventional cells that present this kind of atypia, which are the ones that have been infected. They are pathognomonic or viral infections. Also some thromboembolisms that I'll discuss in a moment. We were able to visualize the infectivity and multiple particles inside of epithelial cells, and we confirmed in many organs that this macrophage activated syndrome was present. So in a way, in most of the patients that have this respiratory illness, the attack starts in the oropharynx and in the nose. The virus infects the epithelial cells, keeps going down the tract, and produces this kind of respiratory failure that is accelerated by a very cytokine storm-directed inflammation. But the group of patients presented very differently. They came, yes, with some shortness of breath and fatigue, but also night sweats, delirium, unable to remember what happened yesterday, some kind of neuropsychiatric disorders and cardiovascular disorders. And this is a 60-year-old male that presented with this kind of symptomatology. See also that the temperature was around 37.1, not real fever, but very increased markers of inflammation, the C-reactive protein over 200, the dimers, and this patient underwent a slow course of complications, of cardiovascular complications, fibrillation, asystole, delirium, and finally the patient also had a multi-organ failure and died of the disease. And when we did the autopsy, one of the things that surprised us was the fact that we were able to see in this coronal analysis of the brain multiple microinfarcts and thromboembolisms in small and large blood vessels that were confirmed by the microscopy, showing in here how much some of the small blood vessels, but also intermediate and large vessels, were completely occluded by these thrombi that affected many different areas of the brain, as well as the lungs and the heart and other organs, which posed the question, could it be that ACE2 receptors are in specific cells that are driving this pathology? And again, we were able, through different technologies, to prove that the ACE2 receptors are also present in the endothelial cells, not of all of the blood vessels, but of blood vessels in specific organs. The endothelial cells in the brain produce the blood-brain barrier. They are very specialized. Years ago, our group was also the first to demonstrate that these cells have a phenotype of the multi-drug resistant transporter protein, the ABC P-glycoprotein, in the surface, so producing part of this barrier, and ACE2 receptors are also part of this phenotype in the cells of the endothelium of the brain. We realized that this was also the case in the endothelial cells of the heart and of the lung, producing a disease that is very different, and somehow we are starting to compare it to cancer. Why? Because the COVID-19 disease produced the SARS-CoV-2 virus can attach to a specific epithelial cells, but at some point when enough damage in the epithelium is produced, it penetrates into the blood vessels, producing a viremia. And this is the concept of metastasis. Even though we have used metastasis for neoplastic disorders, a metastasis in medical school, it's assigned to a pathogen that can be a transformed cell, but also a virus or a bacteria, when it moves from a site of origin, a primary site, into either the local or further down in peripheral other organs. So SARS-CoV-2 has learned how to penetrate into the blood vessels, how to metastasize into other organs, into the lung, into the kidney, and into the brain. And in the brain, to produce damage more than in the neuronal or glia structures, in the endothelial cells that have the receptors that produces an endothelitis that together with the amount of inflammation produces thromboembolisms and a very, very difficult disease for which most of the patients then die. And part of what we learned was translated with our cardiovascular team, because they realized that either prophylactic or therapeutic doses of anticoagulants were able to help some of the patients that were very sick. And in a study that we recently submitted, and it was accepted in the College of Cardiology, we can see that anticoagulants help these patients and rescue more than half of the patients that otherwise will die of a coagulopathy that it's very intense and affects many organs. So based on all of the information and what we have learned, we are trying to produce a staging of the disease in which the natural history of the disease in the context of COVID-19, the SARS-CoV-2 virus, the entry, replication, dissemination, and the next steps, which is a multi-system inflammation and endothelial thromboembolism that it's in many organs, how we can relate the natural history of the disease with the appropriate diagnostic test and therapeutic interventions that will give every patient a better chance of being cured by doing something that will be part of this end-to-end solution. So we believe that, like in cancer, we need to stage in order to all of us understand and the patients to relate to the disease that they have. Because we have produced many autopsies in which the virus was already not present and the antibodies were there, but the patient died of the damage that the virus has produced in many other organs and essentially in the endothelial cells. So as part of the conclusions for these studies, to say that initially conceptualized as primarily viral illness in the respiratory tract, we have also discovered that this is an illness that affects the endothelial cells, produces hypercoagulable stage, that together with this macrophage activating syndrome produces a prominent immune response that continues to damage the endothelial cells, producing this endothelitis. And in some of the patients, when this is very exacerbated and with other comorbidities such as blood vessel affection because of diabetes or hypertension, the coagulopathy and severe hypoxia generates multi-organ failure, leading into specific instances, unfortunately, to death. So if we don't treat at the right stage with the right treatments, and we are more aggressive, bringing some treatments more into the front, we are going to be able to really to help some of the patients that need this more target-oriented therapy in later stages. What else we are doing to share with this group? So we know that the infectivity is very complex. Everybody's talking about the ACE2, but there are other receptors that SARS-CoV-2 uses for entry. In order for the virus to enter into the cell, these receptors needs to be cleaved, and most of the times that happens because a specific protease, one of the most commonly studied, the TERMS2, which is part of the androgen receptor signaling, but there are other also proteases. So the map is becoming more complex, and it's for the reason that together with Bobby Sibra, we decided to start leveraging high-resolution technology in order to explore the signatures of COVID-19. We have used very specific autopsy cases. We are reviewing the data, and we are learning as we are speaking. This is all non-published data. Just to show you that using different platforms, we have been able to start looking at single cell analysis, producing very specific annotations that start to compare the normality in autopsies of individuals that die of accidents or otherwise healthy with what we are seeing in these tissues, being able to start producing maps that they are going to be, I think, very helpful and very unique. And when you look at what we are getting, some of the most interesting functional networks that they are coming up in some of these patients include blood vessel development, for example, which you would expect based on the endothelitis and all of the damage of the endothelium that we have been discussing. And again, also some very interesting maps of cytokine production, which also go along with the cytokine release syndrome and the macrophage activation. So we think that these technologies are going to help us in understanding further at the more cellular level what's happening. We are also doing some digital spatial profiling utilizing the NanoString platform that has allowed us, when we compare regions that they are more normal with regions that they have some pathology, to see these macrophages and to see all of these signatures of inflammation compared to what is the background of normality, which is allowing us to start annotating and also producing some very specific maps that we believe are going to add to our knowledge and maybe identify other targets for both diagnosis, stratification, and hopefully also for therapeutics. Some of these transcriptomes, again, are showing us specific enrichments in different organs, which we believe, again, they are going to help us. We have been using a series of technologies to go down deeper into single cell analysis, and with the help of Bobby Sibra and his team, we are starting to understand what's happening in very specific systems, including, for example, the olfactory bulb in some of these individuals and patients that died, that they reported while sick, that they had lost the olfaction and that they were not able really to taste. And we are seeing some of the pathways that may be critical in understanding what's happening in the context of the symptomatology that we are seeing in these patients. So plenty that we need still to learn, but plenty that we have learned already. Critical to be able to test well, to test with quantitative assays, both for the viral loads as well as for the titration and neutralization of the antibodies, and to make sure that society understands that this is a different disease. This is not just a disease of the respiratory system. This is a disease that is very aggressive. This is a very smart virus that can penetrate not necessarily in our brains, but be able to produce major damage in cognition and other critical functions that we are seeing some of these patients coming from, and revealing through these studies that young people need to be careful because some of these organ damage can extend for long periods of time. Thank you.
Thank you, Carlos. That's fantastic. Much appreciated. Super interesting results. There are questions for you in Slido, if you can go to slido.com. And we look forward to seeing you later at the Q&A. Without further ado, I will hand over to Jonah Kuhl to chair the next session.